Hey Fix listeners, I want to take a minute to give you all an update on our DPO, Smile Now Dental Group. In case you haven't heard, we've been opening up locations all across the country for doctors just like yourselves. We started several offices this year to show proof of concept, and it's been off to the races ever since. So if you're looking for an equitable partnership opportunity where you can have a profitable business that supports you doing full arch, I'd love to hear from you. We're looking to add several locations in the next year and want to offer the training and support necessary to make one of those yours. If you'd like to learn more, you can go ahead and hit me up on Instagram at Dr. Tyler J. Tolbert, or shoot me an email at tyler@smilenowdentalgroup.com and say hey. Now, without further ado, let's get back to the show. My name is Dr. Tyler Tolbert.
And I'm Dr. Soren Paape.
And you're listening to the Fix Podcast,
your source for all things implant dentistry.
Why?
Yeah.
And honestly, the reason why before we even started, I asked you right away about it is because especially this podcast is mainly full arch, like implant dentistry, right? But we do like a lot of what I'm doing is the patients that come in, they want to look different. You know, they're sick of their teeth. They want to replace their teeth. They want them to look nice. They've been dealing with these teeth for so long, and they finally reach a breaking point where they're like, hey, I want a new set of teeth, right? I think my teeth are at the point now that we can get to that point. And a lot of these patients too, they're older females, and they're like, hey, Dr. Paape, do you do Botox? Can you do my Botox too? Because they trust me. I took out all their teeth, did a big surgery on their mouth, and they're like, oh, Botox is going to be easy for him to do. So I do Botox on my patients, and I think that this would be a huge practice builder for full arch clinics specifically, because that patient already is trusting you, right? And this is probably why it's so popular in plastics as well, because they already trust you. You already did a surgery on them. If you can incorporate doing, I get a lot of patients that don't like the bags under their eyes, right? So they want to do like under eye treatment. And I would love to incorporate this into our offices. I think it'd be a super easy practice builder. And a lot of our assistants, they are super comfortable around blood. That's all we do all day. So adding something like this in, having them pull blood, spin it, and then do some filler with PRF throughout the face, it probably would be huge for implant clinics in particular.
Absolutely 100% right. We have many clinics doing this, and I'll talk a little bit about Care Aesthetics and what we created there. But if you had to guess the size in billions of dollars of implant dentistry,
I don't know.
You guys know what it is?
5, just to do it. Oh, is it really?
It's exactly 5. Yeah, it's 5
nice.
billion.
I probably heard that somewhere.
Implant dentistry is a $5 billion a year field, and all of dentistry is $25 billion. Okay, so implants is 20% of what we do in dentistry. It's faster growing market than dentistry. It's growing at 9% per year. Dentistry is growing at about 6% per year.
I'm going to say.
Guess what facial aesthetics is?
I'm already 1 for 1, so I probably shouldn't guess. I'm going to say 20.
Oh man.
Oh! I thought we were doing percentages. I was going to say 120 billion right after that. Actually, that's insane. No, that's ridiculous. That's in the wrong industry.
So you're talking about a field that's more than 20 times bigger than implant dentistry. Okay, this is a point that I always make, and I had a couple of experience with this, and one of the reasons why I've shifted my practice to be a lot more heavy on the facial aesthetic side for several reasons. But when and this is what I tell, especially cosmetic dentists, when you do a great case, okay, let's say you do a full set of veneers, you do a full arch case, etc. Yes, it's very profitable. Absolutely, I agree, right? I don't know what you guys charge for your full arch cases, but let's say $25,000, and after all the expenses, etc., your take home is 10, 15K, let's say, less the complications that may happen, etc. But this is one time. You will make that money one time. If you've done your job correctly, that should stay in the mouth for at least 10 years, at least, and ideally 15, 20, I would say, right? So now you're just doing hygiene on them, not making a whole lot of money, and that's your recourse to see these patients. But that same person, just like you said, is probably, if they're spending $25,000 to get a full set of veneers done because they want to look better, a nice full arch case, that's the exact same person that is going to spend, and Allergan has done all this research, the average person in aesthetics spends $3,000 per year, every year, right? So that means that over 10 years, they're also going to spend $30,000 in facial aesthetics. And if you can convert those people to go more natural by doing PRF and lasers and things that don't cost our practice that much money, right? And we have a protocol where we've developed actually where we combine laser therapy with PRF. It takes us 1 hour to perform. Half of it's done by my dental assistant, the blood draws, the microneedling, etc. Takes 1 hour, okay? $1,400, and we recommend the patient do it twice per year to be more youthful. So they're spending $2,800. It doesn't even cost us $50 to do the treatment. Half the treatment's being done by my assistants, and I'm sitting there racking $3,000 a year every year. Like, I work in our practice. We actually had to hire another associate periodontist because I was getting busier and busier doing the facial stuff. And I was like, man, this is way, way, way easier and more profitable. Yeah, and I mean, I don't have to go chasing all the time.
That's the central
full arch case.
It's
right?
brutal.
You guys know what that's like, right? You got to constantly, it is, right? It's a war out there. And the problem is, and the thing that I hate about dentistry is a lot of lawsuits are created because of fights between dentists and usually it's specialists. Usually it's oral surgeons, right? You make one mistake and now all of a sudden, the oral surgeon's pissed off. Oh, you're a GP and you're stealing all of our big full arch cases. Yeah. We're pissed. Let's go create a lawsuit. It's your own freaking colleague that's, putting you down. It's brutal out there. And we're doing all this for $5 billion a year industry, right? So in the facial field, I just said like, wow, this is so easy. Like, I'm competing against nurses and PAs because no plastic surgeon's doing Botox, right? They want to do big surgeries, right? They always delegate. So I'm like, I'm competing mainly against nurses and PAs. I've got way more facial anatomy training. I've done tens of thousands of injections in complex places in the oral cavity. Like, I mean, you guys know, especially you doing Botox, and you know how easy Botox is. It's freaking the easiest thing in the world, So it's super easy and it's repeat business. So I had my schedule starting to go and fill up. And the craziest thing for me was if I did 2 treatments a year, here's my 10 patients that I'm going to treat January 1st, $1,400 each. That's a $14,000 a day. It's all profit. And guess what? They all rebook for July 1st and 6 months from now. So I don't have to go July 1st, go find a bunch of new patients and beg my GP colleagues, like, please send me connective tissue grafts or please send me those intrabony defects. I'm really good at all this stuff. I graduated from Bern, Switzerland. Please, please, please. Let's go for dinner, please, right? And that's what it's like. So when I switched from that to like, holy shit, my schedule was full. I was doing 1 day a month on just Fridays. Now it's completely full. And now I'm opening 2 Fridays a month to do it. And then it was every Friday a month. And then at one point, I was making so much money for Dr. Cantor's practice. This was during COVID, where we were not allowed to do research anymore because of COVID. So we had to stop all these animal projects. I went and worked 4 days a week in private practice and 2 days in a perio practice, 2 days with Dr. Cantor. Dr. Cantor said, Dr. Myron, you are making so much more money in facial aesthetics than as a periodontist. I don't want you to do any more perio in my practice anymore. You focus on facial. I'll go hire another periodontist, and I just did facial aesthetics. So
I'm definitely going to be.
Very, very.
I definitely will be kind of starting to work on incorporating.
You just changed.
Mike, I do have a question.
Trajectory. We were going to go do some zygos down in Brazil. He said, "Screw that."
Why do you do zygomatic implants?
All the cares
complications. I am curious, when you have these patients come in, like, what's your general protocol? I mean, you like what exactly are you doing? Where are you injecting? Is it patient dependent? Are you kind of like generalizing it for every single patient? Like, do they all kind of get the vampire facial with certain PRF in certain places? And then are you doing Botox on all these patients? Is that like an added benefit for those patients? What are the fees you charging for those? I'm definitely curious.
So we always like to do the regenerative protocols before Botox. And the reason why is because let's say I want to regenerate tissue. So let's say I can see somebody's got visible crow's feet. I want them to like make the motions and I want to be injecting the PRF in the right locations, right? If they do Botox first, now they're paralyzed. I can't tell where those lines are, and I don't know. I can't inject as precisely. So we always do the protocol and then Botox after. All my patients I see 1 week after the regenerative protocol to see how they're doing. And in that follow-up appointment, that's when I do the Botox. And we charge $12 units for Botox, which I think is probably pretty common across the United States. And about 40, 50
in terms
units
of how
for,
things
this area
relapse.
here.
So like with Botox,
yeah.
you're depending on what you're using, I suppose, and a person's metabolic function, how active they are, they probably have anywhere from 2 to 4 months before they're coming back for more Botox. Do you have a longer relapse period with some of the more regenerative protocols, or is it still kind of a similar cycle? 6.
Now we would say 6 months, which is pretty common in the regenerative world. So even most laser companies recommend every 6 months, and PRF same thing. And this is not coming from me necessarily. It's like the microneedling companies that have been doing these vampire facials for years and years. They always say start with 2 or 3 treatments about a month apart to get the body going, making some collagen. And then
at
do
your
one treatment
facial
every
aesthetics
6
course,
months.
do you go over like the vampire facial? Do you go over the where to inject PRF and Botox, all of that stuff there? Okay.
Not Botox in that course. No, we teach that in a more advanced course. But if you already do it, already know where to inject Botox. But yeah, we have like a series of a couple courses that people kind of gradually get better and better. The nice thing with the PRF is, it's so safe that nobody feels uncomfortable going back to their practice on Monday.
So you actually
"All right,
have
let's start
PRF
injecting this
before
everywhere."
Botox.
So it's
and
extremely
Botox
safe.
is very easy. Like it's
Yeah, definitely.
that's really cool. I'm definitely impressed by that. Yeah, I actually the reason like one of my assistants in particular, she has really, really bad bags, and that's like a huge concern for her. And she keeps asking me, she's like, "Doc, can you please do the PRF? Can you please do the PRF?" And to me, I was like, I don't know, on the under eye area, like I don't really want to mess with that. Meanwhile, of course, we're doing the full mouth. But I think taking a basic course like this, and like you said, it's super safe if you're following the right protocols and everything like that, is such a game changer for dentists, and it's such an easy value add. Any single cosmetic case that you come into the office, you could easily be like, "Hey, you're coming in every 6 months anyways for your follow up to get X-rays done. Let's just quick put you down. We'll do the full facial. Maybe we'll even give you a little bit of a discount if you accept treatment with us for the full arch, and then go from there. And then you have a continual patient that's paying." At my office, I charge $250 for the X-rays and everything, and then an added $1,400 on top of that. That's really nice continual revenue for an office.
Hey guys, I just want to take a beat to talk about one of our sponsors, SIN 360, specifically their full arch digital workflow. Here at the Fix Podcast, we've been using SIN for about 2 years, and one of our favorite integrations from this workflow is the Micron Mapper. Photogrammetry is an absolutely pivotal technology that has changed the way full arch is being done. It's allowing us to capture implant scans in under 5 seconds with micron level accuracy that's beating any type of scannable verification jig or analog verification jig, what have you, and it's able to do it in under 5 seconds. And guys, SIN 360 is absolutely giving this thing away right now for $699 a month for 39 months with 0% financing. Think about that, $699 per month. That's about the cost of an analog conversion or fabricating an analog verification jig, or maybe even just a scannable verification jig. So I highly, highly, highly recommend you try this out. It's one of the most pivotal investments that you can make in a full arch digitally capable practice. To learn more, visit sin360.us/thefixpodcast and get yourself a Micron Mapper today.
Yeah. Dr. Cannery set this up so smartly because he would tell the hygienist, look, and actually gave them bonuses, but he would say, what I want you guys to do is start learning how to do microneedling with Dr. Myron, okay? Because then what I want you to do is if your patients are coming in every 6 months to do dental hygiene, I want you to add skin hygiene. And that's going to be a 1-hour appointment. So these hygienists, what they would do is if they had an 8-hour day where they were going to do 8 patients, 8 hygiene appointments, they could actually do 4 patients and do 1 hour of dental hygiene, 1 hour of skin hygiene, 1 hour of dental hygiene for the next patient, 1 hour of skin hygiene.
Wow.
And he paid them $10 more an hour to do the skin hygiene. So when those hygienists were with the patients, They were constantly talking to patients. Yes, Dr. Myron does my Botox. Dr. Myron did my microneedling. These are great services, etc. And then that's how we started to get it rolling, because the hygienists are spending so much time with the patients, and most of these hygienists want to have these treatments done themselves, that it's really good when they're just like, yeah, he does me. And, if you've done their surgeries already, of course, it's going to be a very easy sell.
Yeah, that's fantastic. Yeah, so I do kind of want to pull a little bit back into dentistry itself, right? So obviously we've talked a lot about facial aesthetics, a lot more than I ever anticipated, and perhaps I was wrong in that, but I'm glad we did, because it's actually opened up probably the next course that Soren is going to drag me to. But seriously, I do appreciate the perspective, and I didn't realize how transformative that could be. I always just kind of saw it as an adjunct to the dental stuff, but who knows? I mean, if you get really into it, the dental stuff can be an adjunct to the facial aesthetics. But so in terms of, we talked a lot about what PRF can do for, you also mentioned soft tissue around implants. And so my curiosity about that is that typically something where I've already placed the implant and maybe I have a soft tissue defect and I'm trying to improve the soft tissue around that? Is there something that I can be doing intraoperatively when I'm placing the implant at immediate placement? I've heard of PRF ponchos and things like that. Can you talk about intrasurgical application and then post-surgical recall application?
Yes.
Okay.
Yeah. So it's much better to use it during surgery. And exactly, for those that don't know what the poncho technique is, it's a great technique.
Oh, wow.
In fact, if there was only one place in all of dentistry where PRF was used, that would be it. It is my favorite. Okay. You take the PRF membrane, you fold it in half, you take a 15 blade and just punch a little hole through it, and then you put the abutment through the PRF. And when you place it, now, especially on immediates, what I try and tell people is, like, immediate implants come with more risk than delayed implants, without a doubt, right? There's a higher prevalence of early implant failure and higher prevalence of periimplantitis, years down the road. And let's say you're just doing a very simple basic case, right? Lower first molar, most common tooth that's extracted. When this tooth comes out and you place an immediate in there, that implant, the defect size is like 10 millimeters, let's say, right? And you're placing a little 5 or 6 millimeter implant, which means that you have 2 millimeters, let's say, of space all around this implant for bacteria to get in there, right? So if you did this case delayed, right, you'd put the bone graft in, membrane, wait. When that implant would be placed, let's say you're placing a bone level implant, right? The entire implant is going into the bone, and the roughened portion of the implant is embedded in bone already. And if you use the tissue level implant, the entirety of the roughened portion of the implant would be buried in bone, and what would be exposed for the bacteria would be only the polished surface, which bacteria don't like as well, right? So you're very safe there. When you do the same thing and you got this little 6 millimeter implant inside this big 10 millimeter hole, you're engaging obviously in the furcation area, but all the space now exists. And when we go to AAP meetings and we discuss this among periodontists, everybody agrees we're going to pack the gaps with allograft, right? So everybody agrees on the material to use there. What to do with soft tissues, man, you get 10, 20 different answers from different people. Everybody says, we developed this technique, we do it this way, we do it that way. Some people say you need a connective tissue graft. Some people say, unless if it's this height, you need a connective tissue. If it's like this, you do this. So there's all kinds of, different ways to do this. And even if, let's say, you placed an abutment, an abutment there, and you approximated the tissue as best you can, or you made a custom abutment, etc. Like, the reality is that you don't really have true primary closure, right? Like a little bacteria that is literally 5 micron in size, if you don't think that it can just go squeeze down there, and then now, where's the bacteria? He's floating around down here in a space where there's 2 millimeters of open space. He can literally go float right to the roughened portion of an implant, and boom, he's now connected to it, attached to it. And I tell the residents in the perio department, like, if this happens, you just started periimplantitis. There's no going back now. Very difficult to treat. We don't want bacteria. And I always tell the residents, the day you place the implant is the most important day of that implant's life, because the decisions you make today are going to affect what this person's going to have to live with for 10, 20, 30 years from now. So the guy that invented the poncho technique, it was a brilliant idea. He said, why don't I, the goal was just where this abutment is, whether it's custom or not, when you're trying to get approximation of the tissue, why don't we just put PRF everywhere around here? Okay. And by doing so, now you've put like a super concentrate of leukocytes as well. That's why they call it leukocyte and platelet-rich fibrin, or LPRF, as you guys know. Now, the bacteria that's trying to get in there, that's the worst place the bacteria wants to be, because that's where you're better at fighting infection. You have more leukocytes there. So I think the technique is brilliant, and amazingly, it literally, you just need one tube. You can use one tube, balance it with a tube filled with water, and the tubes cost $1 each. And if you did that for every implant you placed,
we got a bunch of
sure
implant dentists listening to this now. Better like, okay, I got to do that. I want to start doing this Monday. What does the armamentarium look like? What is just like a brief description of that protocol to do just the PRF poncho part?
Yeah. So, all these companies that have PRF equipment, they always sell them as a starter package, right? Where typically the kits are anywhere from, $3,000 roughly. And it'll include the centrifuge, the 2 tube types to make the solid PRF and the liquid PRF, butterfly needles, and then all of the hand instruments, the PRF box, the tray, the bowl, the tube holders, everything else that's included. So literally, when you buy one of those kits, you get everything you need to start. And the Bio PRF kits, which is the ones that we developed in Switzerland, those ones actually come with my online training program. It's 8 hours. It's my actual PRF course. It was just recorded for online, and it comes with everything. I mean, everything from, how to turn on your machine and program it, to what is PRF, why it's different than PRP, to all the clinical indications. So it's literally our full day program, and that's included with it, as well as a copy of my book, Understanding Platelet-Rich Fibrin. So you literally get like a lot of information. Yeah. And the course, the reason why we did this, for me doing a lot of the research in the space, you guys can imagine, I want PRF to be successful in everybody's practice, because when people associate PRF, they think of, Dr. Myron, so to speak, right? So if everybody's having bad experiences and it's not working well, they're going to be like, well, Dr. Myron is full of shit, right? So I don't want that. So we try and, put as much of material in these when they purchase that. And the course, we made it used to be 1 year only, but we now made it lifetime access. So the doctor that has it in his practice, it's lifetime access, which means that maybe you hire a new dental assistant because one of them left you in 3 years from now, and you want her to be your PRF queen and help you with PRF and all your surgeries. You say 3 years later, I need you to go watch these
where can they
videos
purchase that from?
And
if
then
they want to do the bio PRF?
So, yeah. That's Bio PRF. Yeah, the website's bio-prf.com. And the starter package. And for those that take courses,
so that would be a single unit application. So. Do you what are your thoughts on application for full arch treatment? Are you an advocate for, I see some people who, because a lot of times we're sedating these patients anyways, right? So they just draw blood as soon as they get an IV in. And then, but are you an advocate for layering PRF everywhere prior to closure? Like, where do you see it being the most applicable for full arch based cases?
Yes. Mm-hmm. So if you're doing bone grafting, adding it to make your sticky bone, keep your particles there a little bit better. And then, yes, during closure, we just literally put PRF membranes everywhere. The goal is, and what we teach people in courses, anywhere you make an incision in surgery, you want to have, when you go to close this, you want to have a PRF membrane laid here. So if this is my incision, right, I open up, I do this big bone grafting, place some implants, put a collagen membrane or whatever you're using. When I close up, I have a membrane that's here all the way down. Okay. And so that if there is bacteria that want to go in there and try and contaminate what you've done, because again, same thing. Yes, you have primary closure, but it's not true primary closure. A little bacteria that's 5 microns in size can go squeeze in there. So rule of thumb, and this is in all fields of medicine, ortho, plastic surgery, etc. Anywhere you make an incision, when you close up, There's a PRF membrane there.
Mm-hmm.
So even our plastic surgeons that do rhinoplasties, etc., and they make
Very cool.
little incision lines here,
Very nice.
when they close that up,
So
they
you're
always
using
put a PRF membrane
the
right there.
solid
Same way we do in
PRF
dentistry.
tubes to make the membranes. You're using the liquid PRF tubes to use the sticky bone, correct? So it coagulates and forms that. If you're like in the beginning of a case, at what point do you really recommend spinning that? Because I've run into the issue, right, where maybe I'll spin my PRF and then it coagulates too much prior to getting to the to using the sticky bone. When is kind of like the optimal timing for like spinning the solid versus and liquid PRF?
Yeah. So you obviously don't have a BioPRF system because you're probably using fixed angle, I'm assuming.
Yes.
Is your machine like a 45-degree angle? The tube is going like this. So when you use a fixed angle, you're actually driving, when the centrifuge is spinning, you're driving the cells against the back wall. Okay. When this thing's spinning fast, right? The G-force is pushing the cells towards the back wall, but you actually want to clot. Yeah. You don't want to clot. And where does clotting always start? On a wall surface. So by forcing them there, yours is probably going to stay liquid for about 15, 20 minutes. Okay. When you spin it horizontally, so the tubes, they actually go like this, there's no more G-force that's pushing it against the walls.
Okay.
So on a horizontal system, it'll stay liquid for 4 hours.
Probably better for full arch.
Okay, so you got way more time. Yeah. And so that's a modification that was made. Another thing too that definitely. Another thing that you can do as well is we've realized there's 3 main things that affect clotting. Okay, so the first being the tube surface. The more hydrophilic it is, the more water loving, the faster it clots. The more hydrophobic, the longer it's going to stay liquid. So number one, if you use the better tubes, and you can get those and use them in your machine right now at PRF, you're going to get it to clot faster, and you're also going to get it to stay liquid longer. That's number one. Number two, we know, and I don't know if you're doing this already, oxygen is one of the drivers of clotting. So the red top tubes, we always pop the lids, and we want to expose them to oxygen. Even if it's clotted, and I did my 8-minute protocol or 12 minutes, whatever you're spinning at, when it's done, even if it's clotted already, I still pop the lid and I want to expose it to air for another 5 minutes. The air, the oxygen, induces it to clot further. On the liquid PRF tubes, never pop the lids until you're ready to use it. Okay? The third thing, and this will help you out tremendously, we realized that the conversion of fibrinogen plus thrombin into a fibrin clot is enzymatic. And enzymes don't work well at colder temperatures. So we actually created what's called a BioCool device. It's a little like cup-shaped device. And when you put the tubes in there, it keeps the liquid PRF tubes between 8 to 10 degrees Celsius. And then the enzymes can't convert as efficiently. So even on our horizontal system, it'll push from like an hour that it stays liquid all the way up to more than 4 hours. And on a fixed angle, you'll go from 15, 20 minutes to like an hour and a half. So that'll give you just by cooling it. And if you want to make your clots clot faster, and we bought this, you buy a tiny little incubator and keep your incubator set at body temperature, 37 degrees Celsius. That's when enzymes are most effective. So when I have the red top tubes pulled, okay, my team, they pull off the lids, oxygenate the red top tubes, they put it in the incubator until we're ready to use it. That'll make it clot a lot more effectively, and the clots will be stronger. Related to your question on timing, I have my dental assistants do all of this. Okay. They do it all 15 minutes before any procedure starts for me. They're in the room, they're doing the blood draws, they're doing the spinning, they do all that stuff. Okay. My whole team does all the blood draws and all the spinning, and we've trained them obviously how to do that. If I have a patient that's on anticoagulant therapy, typically people will say like, oh, should I do a double spin or triple spin or spin faster, this, that? A person that's on anticoagulant therapy will not have different levels of platelets and leukocytes or red blood cells. So if the role of the centrifuge is to separate cells based on their density, the protocol is the same. The difference is it's going to take them longer to clot. So what do you need to do? You need to do 3 things. You need to make sure you're using the hydrophilic tubes.
You need to warm it.
You need to pop the lids, and instead of waiting for 5 minutes, maybe we need to wait for 20 minutes, okay? But they'll always clot, and you need to use an incubator. Okay, so that's basically our protocol. There are little, when you talked about doing it from the IV line, we actually sell them also at PRF, but they're little like adapters that you can use, and then you just do the blood draws. We do that all the time in sedation. Okay, you draw that blood just like you're doing before. Okay, and I hope you're drawing them in one of the vacuettes. Is that how you do it, or do you draw it in like a tube and then you do it that way? Yeah, that's the right way to do it. Some people, they'll grab like a big 40 cc syringe and draw up 40 cc's that way from the line, and then inject 10 cc's into each tube. I tell people try to avoid doing that because the proteins, the reason how clotting starts is from the proteins that are found, which will absorb to the surfaces. So if you fill a 40 cc syringe just by drawing it, some of those good proteins that are needed are now binding to the syringe wall, and then you go put it into each of the 10 cc tubes.
What are some other common mistakes that you see, like maybe specific to dentistry, in terms of the blood draw, how things get spun, how it's processed? I mean, you talked a lot about the sort of post-process in there. What are some other things that are affecting the effectiveness of the PRF?
Yeah, I would say that there's a lot of people don't. Well, there's three things really. First, people don't understand the difference between RPM and RCF. And so there's a G-force and an RPM. And what happens is, let's say, I have my centrifuge and I'm spinning, okay? There's a certain amount of spinning that's going to occur at a certain G-force. So let's say I invent a perfect protocol, and my protocol is designed only for this machine. So let's say it's 1,000 RPM. Yeah. And it creates a certain G-force that will separate. If we start to do a machine that has is like twice the size, and you still spin at 1,000 RPM, you're actually going a lot faster, right? Yeah. You're actually going a lot faster this way. And so what happens is what happened? I don't know. Is my video still going okay, or is it?
It's getting a little choppy, but it'll be okay.
So the rotor size from here to a bigger size, you cannot use the same RPM. You need to specifically design a protocol here and use it there. So I see a lot of people, they'll go to Facebook groups, let's say, and they'll say, hey, I just bought a centrifuge. What protocol would you recommend using? You get all these answers, 1,000 for 10 minutes, 1,300, and da-da-da. That's completely incorrect, because every protocol is designed specifically for one machine. Okay, so that part there is very, very important. And then additionally, the tubes matter way more than the centrifuge, and people buy the tubes for like $1, right? And that decision you make with the tubes will matter much more than the centrifuge. So those are the two most common errors that I see.
Hey everyone, I apologize for this quick interruption on the podcast. Dr. Myron's video actually stopped working at this point due to just running out of battery. So I'm going to try to give you a quick summary of his final points, and then I'll talk a little bit about how to get in touch with him or his program. So the last thing he was really talking about was actually heating PRF. And when we heat PRF, it goes from lasting from 2 to 3 months to 5 to 6 months. And through BioPRF or PRF EDU, they actually have a heating element that you take the PRF, put it in there, and it allows those membranes or solid PRF to last quite a bit longer. That was his first point. The next thing he started talking about was, I actually asked him what the biggest change he's seen in the dental or blood environment is, and he said exosomes. And what those are, there's a lot of future potential for these to change how medications react. They're something that can prolong certain medications. Let's say insulin. If a patient needs to take insulin every day, it might change to taking it every week using these. So he thinks it's the biggest thing he's seen in regenerative medicine, and we're really excited for the potential of this to come. Finally, he discussed how to get in touch with him and how to learn a little bit more about PRF. And the best thing you can do is go to PRF EDU or BioPRF online, and he has multiple courses on there that you could sign up for and take. I actually, since recording the podcast, I went to his course, and it was excellent, and we purchased all this stuff, and we are doing PRF. We were doing PRF before, but we're doing a lot more of the facial PRF stuff in my office, and it's been excellent. So we wanted to just thank Dr. Myron again for coming on the podcast. Thank you, Dr. Tolbert, for doing another wonderful podcast. If you guys have any questions for Dr. Myron, you can reach out to him on Instagram. And hopefully, once again, you enjoyed our podcast. Thanks again. Bye.